Welcome everyone to today's webinar. We are glad that you can join us. We are going to hold for just a couple minutes as people filter in, and then we will get started. Okay, I see some people filtering in. We're going to hold for a couple minutes, and then we will start the webinar. Okay, I see sort of people still trickling in, but it's starting to slow down a little. So I think we'll get started. I want to welcome you to today's webinar, First Do No Harm, Addressing the Patient Safety Crisis. If we can go to the next slide, we have a little bit of housekeeping. Just at the top here, you will see at the bottom of your screen, there is a question and answer box. That box is open as we go through our presentation today. If you have questions for any of the speakers we have, or questions about the issue we talk about, some of the solutions we talk about, please put them in that Q&A. We will be having a little bit of a discussion at the end. If you go to the next slide. My name is Hazel Law. I'm a policy analyst at Families USA, and I am so pleased that we are joined today by two amazing leaders in the patient safety space, Sue Sheridan and Leah Binder. Sue comes to us from Patients for Patient Safety US, where she is a founding member. It's a network of individual people and organizations who are aligned with the World Health Organization and focused on making healthcare safe in the US. It is led by people who have experienced medical error as either a patient themselves or within their families. And I will let Sue tell you all a little bit more about that later in the webinar. We are also joined by Leah Binder from the Leapfrog Group. The Leapfrog Group is I should say, Leah's the president and CEO, and the group is a nonprofit working towards improving the quality and safety of healthcare in the U.S. They were founded by large purchasers and employers, and for more than 20 years, they've been collecting, analyzing, publishing data on safety and quality in order to push the whole healthcare system further in delivering safe, quality healthcare. So today we're going to talk a little bit about this national patient safety crisis. We're then going to talk about, some of the real families, the real stories at the core of this crisis, and how coming together and working towards a goal of safer and quality care can be achieved. We're going to talk about one of the steps we can take in the right direction, the potential implementation of a national patient safety board, and then a little bit about what's next. How can you stay involved? How can you get into this fight? And again, we will open it up for Q&A at the end. During the Q&A, we will be joined by Robert Ferguson, who's the Chief Policy Officer of the Pittsburgh Regional Health Initiative, my apologies, which convenes the National Patient Safety Board Policy and Advocacy Coalition and can help answer any questions that people have about the board or about next steps. So now it's my privilege to turn it over to Leah, who's going to sort of talk to us about what the national patient safety crisis is, what's happening, where is it happening, and who is affected. So I will turn it over to you, Leah.
Thank you, Hazel, and thank you for having me today. I'm pleased to be joining you. Leapfrog has long worked in alignment with Families USA, so it's really great to be able to join you. But the subject is a troubling one. We're going to talk about patient safety. And, patient safety sounds like a very nice thing. Safety is something we all support. Our grandmothers supported it for us when we were growing up. But what we're actually talking about when we refer to it is avoidable death and suffering that is happening in this country. And we can do something about it, but we aren't doing enough yet. So that's what we're talking about today. And I'm going to show you how that plays out. Next slide. So when you're in a hospital, it is very easy for a mistake to be made that can be catastrophic to you or your family member as a patient. It is very easy. It's very scary when we think about it. If a dose that you're supposed to have of a medication is missed, that could hurt you. They missed a lab test report that said something about your treatment that was an error. They didn't wash their hands, and that can easily lead to a hospital-acquired infection, which are a major problem in hospitals, excruciating to experience, and in many cases, deadly. They forgot something that is important to your care that could result in your harm, gave it to a different patient. That happens a lot, believe it or not. They give the wrong medication to the wrong patient. They didn't tell the nurse, or they forgot to tell the nurse to watch for some sign or some symptom that was a very troubling sign for you as a patient. Patients fall. That can actually literally lead to death. Falls are very, very harmful and scary for patients. Now, there's a few things we call never events, such as leaving a sponge in after surgery. That happens. Or people just get distracted. You can see from this scene from a healthcare environment how distracting the whole environment is. It's very easy to lose sight of that patient, yet the patients are at their most vulnerable moment in their entire lives, probably in that bed right now. And so they need everybody's attention. And sometimes that doesn't happen. So it's very easy for a mistake to be made that is catastrophic to the patient. Next slide. So the Office of the Inspector General, which is a independent body that looks at the performance of healthcare in the United States Department of Health and Human Services, which is a very large agency. So they look at all of the factors that are influencing the how we govern health, basically, in this country at a federal level. And one thing they looked at was how often are these mistakes made in hospitals, and to what extent do they harm patients? And here is a highlight of the findings. You can look them up yourself. There's lots more that are as troubling, but here's one. Next. They found that, back. No, back, thank you. Oh, this is a PowerPoint 101 here. One little tricks in the PowerPoint, sorry. What they found was that 1 in 4 people who are admitted to a hospital in the United States suffer some form of avoidable harm. 1 in 4. Now I want you to all think, would you get in your car today and drive anywhere if I told you had a 1 in 4 chance of being harmed during the drive? No, none of us would drive. I'm certain of that. I certainly wouldn't, I can tell you that. But 1 in 4 is an astronomical level of harm. It is unthinkable in any other industry. Next slide. And the problem that is most troubling about that, besides the fact that's a harm, that's avoidable, is that a lot of people die. So this is a photo of actually the Washington Monument. You can see Washington in the background, but in the forefront is a city called Arlington, Virginia, which many of you may know. Airport's in there, and Amazon just moved to headquarters there. They have a population of 232,000 people, which is roughly the number of people that are estimated to die in American hospitals from avoidable errors. That's a lot of people. That would make it, if we counted it this way, it would make it the 3rd leading cause of death in the United States. A very significant harm, and it is avoidable. I have to repeat that. It's hard to avoid because I showed you how complicated a hospital is, but it isn't by no means impossible. And some hospitals are better at it than others. Next slide. There's also a financial cost. It is not as important to us at Leapfrog and most people. It's not important to us how much this costs that we have these harms when we look at just the level of tragedy that's involved in avoidable harms happening in hospitals. But there is a financial cost, and it's worth noting. So there's a study done. It was a few years ago now, but our data tells us it's still absolutely relevant. And that's a study that was in JAMA and Atul Gawande, a number of authors, but Atul Gawande was one of the more prominent of them. A team from Harvard went into a health system in the South. They didn't name the health system, and they wanted to count. They had a question. How much extra does it cost various payers when there's a surgical site infection, which is almost, not always, but most of the time avoidable? Next click. So they looked at three main categories of who pays for this care. By the way, fundamentally, who pays for this care is you, the consumer. You're paying through either your tax dollars or from your paycheck. Somewhere along the line, you're paying for all of this care. However, let's talk about these main known payers. Medicaid. Medicaid paid $900 extra every time there was a surgical site infection. We're not talking about the cost of the surgery. We're talking about the extra costs that were associated with a surgical site infection, which causes pain and suffering to the patient. Pain and suffering, $900 were paid for. Medicare paid more. So click. Medicare paid $3,000 extra every time there was a surgical site infection. Now there's another category. My organization, the nonprofit, as Hazel just said, is a nonprofit founded by employers and other purchasers of health benefits. They wanted to improve the safety and quality of care in American hospitals. And so they pay for their employees directly. Most large employers do. How much extra did they pay? Next slide. They paid a lot more. Click. They paid $39,000 extra every time there was a surgical site infection. Now, $39,000, that's 10 years ago, it's more now. $39,000 would certainly fund at least some jobs if employers were not having to pay that amount every single time for the price of a surgical site infection, which is not wanted and avoidable. So this is costly. It's a big cost to American families and to all of us. And the cost, as I said, the most important part of the cost is not even the dollars. The most important part of the cost is the suffering and the death that we can avoid. We just have to work together, and we have to make it clear as individuals, as citizens, that we will not accept this anymore. This has to stop because hospitals know how to stop. Next slide, please. Don't keep going. We've got a little drama in there. Okay. I need to add one thing that's also troubling about all of this, which is that there's health inequity in everything. There's health inequity in patient safety. Leapfrog worked with Urban Institute and AARP to do a study recently looking at all of our data and a huge amount of data from AHRQ, and concluded that there were significant disparities in who's more likely to suffer some of the worst harms. This is one harm, which is just many of the injuries, pressure ulcers, for example. Black patients in the same hospitals were 3 times more likely than white patients with the same payer to suffer a pressure ulcer, which is an excruciating wound that can be prevented from getting to the level of deadliness that is measured in that metric. And I'll tell you, my grandmother died of that. So I saw it myself. It is, nobody wants their grandmother to die of that or themselves. That is something where Black patients are 3 times more likely to die from it. So in all areas, this is a major issue that should be addressed. It's a national crisis. Next. It's a national crisis. That's why we support the National Patient Safety Board. We've been part of that coalition from the beginning because we believe strongly that this has to be treated as a crisis. It has to be a national priority. It has to be leadership put to it. And all of us have to be able to get engaged in it. But here's some good news, because it isn't that we haven't made any progress. We have made progress. In the past decade, we have actually seen a reduction in certain of patient safety events, common events like falls like in certain infections, like certain errors that are common, we have seen a reduction, and it's significant. This was a study in JAMA in 2022 by some researchers who looked at millions of patient records to observe that there were reductions in errors associated with these errors, these avoidable problems. These were all avoidable issues in a whole category of treatments that are common in hospitals. So in major surgery, pneumonia, heart failure, and MI, the rate of injury and accidents and infections that were avoidable in those categories went way down. You can see the red lines, the red bars there are the rates that were that we knew about in 2010, and then the blue lines, the blue bars are from 2019. So in 10 years, we did see reduction. Now, maybe it's not where we want to be. It's not perfect. It's certainly not anywhere near the kind of progress we need to see happen in the next decade. However, it is progress. And for my whole career, I can tell you this, I've been talking about how we never move the needle, nothing ever happens with patient safety. And suddenly we saw with a very significant, very large study, yeah, there's have been progress. So what happened in the past 10 years? Next slide. That had not happened before. Number one, the Affordable Care Act was signed. And the Affordable Care Act has provisions in it, which a lot of people don't know about, that actually require any hospital that gets money from CMS, which is the agency that funds Medicare, they requires them to publicly report on their safety and a lot of those measures. So suddenly we had transparency, which we never had before, and that had a real impact. So you just click it like 3 times next. So we start public reporting, and from that, my organization, Leapfrog, took all that data that we suddenly got publicly reported, and we turned it into letter grades. We did that with world experts on patient safety and a whole variety of folks and research and everything else. But we turned it in 2012, started reporting on how hospitals are doing on patient safety, A, B, C, D, or F. We gave them a grade, and we still do every 6 months. We're putting out a new grade in early May. And you can look it up, hospitalsafetygrade.org, look up any hospital in the country. It's all free. It's public service to the public. So you can know how your hospital is doing, and you can go back to your hospital and say, how are you going to improve? Because they can improve, and many do. We see incredible stories of hospitals that go even from an F to an A. It's possible, it's doable, and you don't have to be a rich hospital to do it. You can do it. And what we have to do as citizens, as moms, as daughters, as family members, is we have to talk to people we know in hospitals and say, we really want you to put that focus on safety and keep us safe, because we can all do better, and we're here to work together. Let's get better. And I think that's what the National Patient Safety Board is about. And that's what all of this great work from Families USA and certainly Sue Sheridan and Patients for Patient Safety, just so many good groups. Let's all work together. And all of you who are watching this webinar, you have a role to play too. Thank you.
Thank you so much, Leah. I found that very informative myself. And I think, talking about the true cost being a really holistic cost, not only to people's quality of life, their life, in and of itself, but also the cost to us as taxpayers, as people who are employees, as people who pay a premium to their health insurance, cost to the system, in a country where we spend so much on healthcare, but we have such poor outcomes. This is so clearly, an issue that we need to be paying much more attention to. And with that, it's my privilege to turn our webinar over to Sue Sheridan, one of the founding members of Patients for Patient Safety US, because as we all know, whenever we talk about an issue with our healthcare system, at the core of that, we are talking about real people, about their families, about the people who take care of them, about the people who love them, and those people and their stories need to be at the core of our work. And so it's my pleasure to introduce Sue, who's going to tell us a little bit about how she got involved in this and the work she's done over the past couple decades. Sue, do we still have you there? Oh, I think you're on mute, maybe. There we go.
Yes, I will. No, I probably won't learn one of these days. So thank you for the invitation. And like Leah, I've been worked very closely with Families USA over the years, especially when I led the patient engagement program at the Patient-Centered Outcomes Research Institute. So I'm glad to be reunited around such an important topic. We can go to the next slide, please. So I'm Sue Sheridan, founding member of Patients for Patient Safety US. We are a US-based chapter of WHO's global network of Patients for Patient Safety that I had the honor of helping develop and lead for 7 years. And we are, like was mentioned earlier, a patient-founded, patient-led organization. We have over 80 organizational and individual champions, including patients, family members, nurses, clinicians, everybody who's been engaged in patient safety events in some way, but all have the spirit and the desire to create a safer, more equitable, more transparent healthcare system. And so, and as Leah was giving you some statistics on, medical errors or patient safety events. I also want to put into the mix a recent report that came out last fall around diagnostic errors, and it was by David Newman-Toger that it came out to say that around 800,000 individuals experience a diagnostic error that either results in permanent harm or disability or even death. And so my story, what brings me here is, you can see on the screen, my late husband, Pat, and my son, Cal, who both experienced diagnostic errors. And so today I'm going to focus mostly on Cal, but I want to share, my late husband, Pat, experience. He was 43 years old, had a tumor in his neck that was removed beautifully, and we were told it was benign, when in actuality, his tumor was cancer. The pathology was done appropriately, but that got lost in the healthcare system. And during the non-treatment, it metastasized through his spinal canal, and they did everything they could to save his life. But the tumor actually penetrated his spinal cord, and they could not treat the spinal cord as aggressively as they needed to, and he died when he was 45 years old. And so we're going to go to the next slide, and I'm going to talk a little more about Cal's diagnostic error. And Cal, now this was in 1995, so this is quite a while ago. Cal suffered brain damage from his newborn jaundice. The clinical term for that is kernicterus. This was a condition that was eradicated in the United States in the 1970s. And it is considered a harm that happens mostly in lower middle income countries, specifically in the African region and the Eastern Mediterranean region. So for Cal to experience this harm in the United States was really quite shocking. He was born normal. He became jaundiced very early on. And there's a very inexpensive test called a bilirubin test. Probably a lot of you on this webinar have had children that were jaundiced that went under the lights. And but back in the 90s, they were doing a lot less routine testing. And so Cal unfortunately fell through many cracks in our healthcare system. They never tested his newborn jaundice or treated it until he was 4 days old. And at that time, it was too late, where the bilirubin, the jaundice in the baby's bloodstream, becomes toxic. And it caused him significant brain damage that he has. He's hearing impaired, speech impaired, mobility impaired, and has lots of challenges as a young man. But I have to say that Cal is funny, he's smart, he's a comedian, and but he lives with challenges that he never should have lived with. So you can imagine, as a new mom and widowed soon after that, how very devastated I was and my family. And so it was, I'm talking about the human cost. Yes, we can talk dollar figures, and that's important, but the human cost is immeasurable. And the cost to the family when there is medical error is enormous. After Cal's harm and after my husband passed, I was $300,000 in debt because I was trying to pay off everything that I could. And frankly, nobody even knew I was that much in debt, and we struggled. And so this is, the family cost when there is a medical error, diagnostic error, is enormous, that I hope someday our researchers will research that. And Leah, maybe we can show those dollars under a patient heading, because we do carry a lot of financial burden when there's a medical error.
Mhm.
So when Cal was diagnosed by a specialty team here in the United States, it was considered that he was the only child in the United States with kernicterus. It's very rare and very, like Leah said, very easy to prevent. Can you go to the next slide? But Cal was featured in USA Today. I had the opportunity to testify in Washington, D.C. in 2000 at a big national summit on patient safety. And after Cal was on the front page of USA Today, I was inundated by other parents saying they had a child with kernicterus. Same story, didn't get tested or treated in time, completely preventable. So what we mothers became was an early warning system for our healthcare system. We were connecting the dots. And, it was shocking that when Cal was identified as having kernicterus, there were 0 reported cases in the United States at the Joint Commission, at CDC, at any, major US healthcare agency. They simply were not collecting the data. So we became that, what's now we're talking about the National Patient Safety Board. There was no National Patient Safety Board back then. So actually we stepped in and started doing the work of a National Patient Safety Board. So if you can go to the next slide. So when Cal was born, the same year Cal was born, other babies were born in Seattle, in New Mexico, in Minnesota, in Chicago, in North Carolina. The same story across our country, and no one was collecting this information. So we moms got together and we started to identify the threats and what could we address going forward. But the threats that we saw was that number one threat, no one was in charge of patient safety. We reached out to all kinds of agencies and everybody kind of looked the other way. So that's not our jurisdiction. So number one problem, no one, and to this day, no one is in charge of patient safety. Number two threat was there was a lack of patient engagement in co-designing care that should be designed around the preference and values and what matters most to us. So had moms been involved in designing how babies are tested and treated for their jaundice, I'm convinced that kernicterus would have been eliminated. Like I said, there was no aggregated data collection from anybody in the United States about this condition. So no one knew this was happening. Like I said, we were flying under the radar. There was nowhere for the parents to report this condition. That was the number one thing that we all wanted to do. We wanted to tell every authority that this was happening and there was no place to report. And so this was just a shocking, it was chilling for me to understand that our country had no one central repository of harms. And the last thing that we discovered was the failure to follow guidelines. There were guidelines. Had they been followed, we believe our kids would have been fine. So these are threats that we identified as moms, and these are threats also that Patients for Patient Safety US gets behind, along with other threats that we've identified around transparency. Next slide. So what we moms did is, given there is no National Patient Safety board or anyone in charge, we decided that we had to be the change makers. So we reached out to every agency we could identify and we invited them to our table. We didn't wait for the agencies to invite us to their table. We invited them to our table. So you can see we work with CDC, the Joint Commission, nursing organizations. We work with the Chief Medical Officer in the United Kingdom. We work with WHO. You can see Leapfrog mentioned here because they included bilirubin screening on their survey. And finally, you can see in pediatrics, with all of us working together, we finally changed the guidelines in the United States that all babies have to be tested for their bilirubin before their discharge. It took a long time. It was hard. There was pushback. At first, we moms were not really very welcome into the system because it was considered that wasn't our space. But this was just a group of 7 moms. Now we grew as we learned that more and more cases in the United States. But what we learned was the power of partnerships. As 7 moms, we never would have changed the standard of care. as 7 moms with all those agencies and then even more moms. That was the power partnership. So that's what we're talking about today, the power that all of you have in changing policy and research and guidelines. And I don't want to say I was just a mom in Boise, Idaho, because I'm a proud mom, but I was a mom in Boise, Idaho with zero experience in healthcare. I had no clinical background. I had no policy background, but just from the pure passion and the hope that this mattered to our country, that babies were being harmed, and partnering with these organizations, we can make a difference. Next slide, please. So fast forward to now, that was 20 years ago. Fast forward to now, part of Patients for Patient Safety US. I had the honor of being appointed to President Biden's Patient Safety Working Group under the PCAST, the President's Council of Advisors of Science and Technology, that we worked for 2 years on creating recommendations for the president to sign as an executive order. It has not yet been signed, but our HHS agencies are already picking up on the recommendations. Go to the next slide, please. And I want to show you there were 4 main buckets of the recommendations. If you read through these recommendations, you can see that they address those threats that we moms and Patients for Patient Safety US have identified. I want to focus on the red recommendation to establish and maintain federal leadership for patient safety. And one of those very concrete recommendations under that was to establish a multidisciplinary national patient safety team. Now, we at PCAST called it a team. It's the same concept as the board that Robert's going to be talking about. And so here we see this concept of someone in charge, finally. This really resonated with the group that was creating this and is resonating with especially the patient community and others to have somebody in charge. You can read the rest of those, but let's move on to the next slide. So what I want to talk about is the role that we all have. Now, we at Patients for Patient Safety US, for the last 20 years, we called ourselves advocates, and we decided as we formed Patients for Patient Safety US that maybe as advocates, we've been too nice. And so we have decided that we are going to now call ourselves activist. Activism is not a dirty word. If you look up the roots of activism, activism has changed, a lot of very positive things in our country and around the world. And so there's this term, positive activism, where it uses our energy of our differences to motivate and inspire change. It draws people closer together rather than pushing them away. And it does not necessarily call an activist, it calls on people, it calls on us to step up, show up, speak up about patient safety. And then last, it promotes the change makers, the stewards, and the responsible patients and stakeholders to influence policy and practice that are intended to make the world a better place for everybody. So as we think about the World Patient or the National Patient Safety Board concept, and thinking about that power partnership that I talked about, and all the agencies out there that support, that you'll see in the coalition for this concept, think what we could do together if we got behind this as a force. And last slide, please. And just going back to Cal, and I asked myself this question: what if there had been a National Patient Safety Board when Cal Sheridan was born? There would have been somebody report to, because you'll hear that the National Patient Safety Board has a patient reporting portal. What if somebody had been collecting all that data that was across our country and aggregating it? Would they have seen? Yes, they would have seen this trend of this harm happening across our country. When Cal was diagnosed, we learned that there had been in the previous 5 years, like almost 200 cases before Cal. No one was collecting that data. So this question sticks in my mind. What if? So I will pass it on to the next speaker.
It's coming back to me. Thank you so much, Sue, for coming and sharing that story with us today. I've had the privilege of hearing it a couple times now, and it never fails to be so powerful in many different ways. And so I appreciate you coming and sharing not only your family's story, but also, what came out of that and the movement that you really were such a huge part of creating. And now I get the opportunity to talk about one of the steps that can be taken to address the problem that both Leah and Sue really laid out for us today. And the step that we're going to talk about today would be the enactment of a National Patient Safety Board. So, in March of this year, there was the introduction of bipartisan legislation, the National Patient Safety Board Act, which was championed and sponsored by Representative Nanette Berrigan and also Representative Michael Burgess in the House, the US House. And what this act would do would create a National Patient Safety Board as an independent board within the Department of Health and Human Services. And the three main functions, which really, Sue, you set me perfectly up to talk about, is to identify and anticipate the harm. So, what is happening and who are the people that it's affecting? To study some of the precursors that identifying and anticipating harm might bring up, some of the contextual factors, like why is this affecting some people over another, where are some of the places that harm or medical error are happening most often, and some of the causes. Are there specific types of practices, types of medical treatment that we're seeing have a lot of patient safety events happening sort of in and around? And then finally, to develop some solutions to try and prevent this harm in the first place. And the main way that the board is going to do all this work is through collecting data that's existing patient safety data that's collected through various HHS agencies, and then aggregating and analyzing that data in a way that an agency within HHS has not really been able to do before, because it can pull it all together to give this national insight. They're going to be studying some of the precursors, the causes, the trends that maybe analyzing this data is going to bring forward so they can understand it a little bit better. And then in partnership with their public-private partnership team, which would have representatives from various agencies within HHS, which would have representatives of patients, of caregivers, of providers, of labor organizations, of experts who study this, who work in the patient safety world every day. They would really start to gain some consensus on what good solutions would be, what good recommendations to make to Congress or make to HHS would be in trying to solve this problem. And this board is really supposed to complement and support all the other agencies within HHS in their analysis, in their partnership, in bringing experts to the table, so that the other agencies can also do their job that they are sent there to do in delivering high quality, affordable, accessible healthcare. And if we go to the next slide, there are just three main things I want to bring up. We could talk about bill text for a long time, but I think it's really important to go back to how is this board going to affect patients? How is it going to affect families? So the first thing is that a National Patient Safety Board would give this issue of patient safety a home at the federal level, so that there's always a place where this issue is being put front and center and being addressed. The second, which Sue has already mentioned, is that part of enacting this board would be creating a patient reporting portal, which would provide a pathway for patients, for their caregivers, for somebody within the healthcare system to report data and experiences. Really give those people a place where they can directly talk to the board and say, this is what's happening to me, and you need to know about it. And then finally, which I spoke a little bit about already, is that this board would be able to apply this patient safety lens onto existing data, and in that way be able to identify and uplift patterns that maybe we aren't able to see otherwise. So if you go to the next slide, that's a very high level overview of what the board would do and what enacting this legislation would do. But what's really important is for us to talk about what is next. How can you stay involved? How can you get involved in this movement? As I go through things, these couple elements we want to talk to you about, I want to encourage people to put their questions in the Q&A box. Questions for Sue, questions for Leah, questions for Robert when we get to the end about the board specifically. But when we talk about bipartisan legislation, it is so important that it has been introduced in the House, but it needs to pass the House. It needs to be adopted into the Senate and pass the Senate. We needed this to be signed and enacted so that the board can really start working for families and people. And one way to do that is to make sure that representatives know this issue is important for their constituents, and that they have support and moving forward on it. And part of how you can do that is to email your representative. Jane from Families is going to be dropping a bunch of links into the chat at this point in time. And we encourage everybody to look at them. We also will be sending a follow-up email so that you can have these all in writing. But the National Patient Safety Board Policy and Advocacy Coalition has put together an easy form for people to email their representative. We encourage everybody to do that and to share it with their networks. Another way you can get and stay involved is to share your story. You know, Leah talked about 1 in 4 people experiencing medical harm. And we really, really encourage people to come forward to talk about what is happening to them and what is happening to their families and use their voices for change. You can do that through storytelling forums on either the Families USA website or on the Advocacy Coalition website. And we really just encourage people to talk to us about what's going on and to step forward. And finally, if you go to the next page, you will see there is a coalition to move this board forward and to get this passed. It is super, super wide ranging. There are consumer advocacy groups like Families USA, patient groups, purchasers, employers, providers. We have a real groundswell of momentum in getting this bill passed and really just putting this issue at the forefront. And we want to encourage people to join the coalition. Staying in contact with the coalition, staying in contact with people like Sue, people like Leah will also give you the opportunity to participate in continuing events, because a board is just one step. We have many steps to go. In March, or in September, there will be a march, the Act Now for World Patient Safety March on World Patient Safety Day that is run by Patients for Patient Safety US. We want to encourage everyone to stay involved with that. But really, we're going to leave the contact information for everyone on the panel today. And we just encourage people to join us in this work, as it is so critical for all of us. When we go to a hospital, we want to get better, not worse. And that's something that we all deserve. I think we can either stay on this slide or we can go back to maybe the slide about the Patient Safety Board. But I want to open it up for questions to talk to our panel a little bit about what they've told us today about the crisis, about the board. And I see we have some questions coming in. I want to start with one for Leah, specifically because Leapfrog Group works so closely with data, with aggregating and analyzing and publishing data. I'm wondering if you could talk to us just a little bit about how you see the role of the National Patient Safety Board at the national level, their role of analyzing and aggregating data being really important.
Yes, thank you. I always want to acknowledge it. Hearing Sue's story is always powerful. I agree with you. It's just such a powerful and very sad reminder of how important this work is. We look at data at Leapfrog. I showed you a little piece of that. And by the way, you can look up whether your hospital is doing that connector screening right now. Leapfrog data on leapfroggroup.org. Just look it up. You can see under our maternity care section lots of information about C-section rates and everything else, but also whether they do that screening. It's very important. So I think that the part of the National Patient Safety Board, actually 2 parts of it that I want to highlight. One is the patient's ability to report in what's happened, some place that they can go, and hopefully the board will have the funding to be able to make sure some follow-up is done, and then to also look at trends and where the issues are and what we need to do. It is so critical. When we look at all the data about these events and incidents, they look like numbers, but they're not numbers. They're individual human lives that have been profoundly affected by a terrible thing that happened that was avoidable. That is a lot of people when we look at these numbers, but they're just numbers and they don't tell the story. And so I think that having an opportunity for people to tell the story to a place where it can be followed up on is critical. And we should have had it a long time ago. I mean, when we issue our safety grades every 6 months, we hear lots of calls. We get lots of calls from people. Oh, that happened to me, or this happened to me. And we wish we could feel confident about giving them back. Well, here's where you report it, so they can follow up and do something about it so it doesn't happen to anyone else. Because pretty much every single person who's ever had a tragedy like this affect them basically says, I just want to do something so it never happens to anyone else. And we just don't have that right outlet, and there's no excuse for that. We need to do it. And there's just one other thing I want to point out is in the legislation that I really like, which is, or it's the opportunity to begin to report on hospitals by facility. And that is really important. Right now, we do not have information. We often report by whole systems, things like that. I don't care about how a corporation is doing. I care about how the hospital down the street from me is doing. So we have to have better reporting. It sounds like a small thing maybe, but it's a big thing for patients and families, certainly for folks like us who really want to understand what is actually happening in our healthcare system. And so we think that this legislation is incredibly exciting because it can bring that leadership and really shine the light where it belongs, which is on the real stories of what is really happening to patients and families.
Thank you, Leah. That is so important. I think it brings us perfectly to a couple questions we have specifically about the introduced legislation that I'm hoping, Robert, you could shed some light on. Specifically, we have two questions. One around the board, like who would appoint board members and carrying out the work? What sort of authority do they have as being board members? And then with the aggregated data that they're going to be collecting from various agencies, will that be shared back to the agencies, i.e. sort of who has this read-in on the treasure trove of data and analysis that the board is going to start working with?
Yes, so with regard to the first question, the NPSB is a 5-member board, would be nominated by the president and appointed in consultation with the Senate, and that they would also serve a 5-year staggered terms. And in terms of who would have access to and see that aggregated data, it would be seen by the NPSB's research and development team, which would be housed within HHS. And that is the same division of the NPSB that would also have a public-private healthcare safety team that would be gaining a consensus and understanding of the patient safety risks and the precursors to injury and harm, and ultimately the solutions to adopt to prevent future injury and harm from occurring.
Fantastic. I'm wondering, with the patient reporting portal, which we've talked about a couple of times now, how is the board going to be sort of filtering through that information that comes through? How is it going to be useful to the board? How are people who are sharing what might be a very intimate, very scary or sad or life-changing event, how's that information going to be used so they know that when they send that information in, it's going to a place where it's helpful?
Yeah, the NPSB is designed as a chain of reactions, and the chain of reactions begins by aggregating all of that data across HHS agencies, including the individual reports through the patient safety reporting system. And then that research and development team that I mentioned earlier, they would be filtering all that data to identify the most frequently occurring major sources of injury and harm, any abnormal patterns or persistent patterns of injury and harm, as well as any racial, ethnic, gender, and social determinant of health and geographic disparities. And those types of findings would then initiate the next step to then understand the causes and the precursors to those findings. And then again, ultimately third, to gain consensus on those solutions to create new industry-wide standards around safety.
Interesting. We've had a super interesting question come in that, I don't know, Robert, you can maybe speak to how the board might address this, but I also think Sue and Leah might have an interesting perspective on specifically in the rest of their work they do on this issue. It comes from someone who's a hospital-based nurse. And she says, I strongly believe that to be a better nurse, we need better patient to nurse ratios. And, I can take much better care of 4 patients than I can 8. So what role does hospital staffing play in patient safety? Is hospital staffing and nurse to patient ratios something that might be addressed by the National Patient Safety Board? How is that involved in the rest of this issue?
Yeah, the NPSB would also include human factors engineers. And I mentioned that's a discipline in particular because they really look at the work environment of frontline workers, and they identify what can be changed within that work environment to enable all frontline providers and teams to achieve safe and optimal care. And we think that there's a lot of opportunity to use technology and to redesign that work environment to prevent injury and harm from occurring. And that is especially the case during healthcare workforce shortages, burnout, and turnover. The frontline teams, more than ever, need a work environment that's augmenting and supporting their work. And again, I'm having standards in place to assure safety in the workplace and patient safety.
Thank you. Leah or Sue, I don't know if you have anything you want to add to that. That was great, Robert. Thank you.
I did have something I could add.
Yeah.
I couldn't agree more that most of what hospitals do is deliver nursing care. I mean, that is most of what they do. And nurses are just an extraordinarily important resource in just all of our lives. And we actually at Leapfrog, one of the things we do is collect data from hospitals that provide it to us voluntarily. We get about 75% of hospital beds represented. Not all are willing to be out there publicly reporting how they're doing on safety. But one of the things we ask about is the ratio of nursing hours to patient days. So you can actually look that up for hospitals on Leapfrog. We believe that holding hospitals accountable for that standard is really a critical part of safety. So it is part of it. And I think we have to consider nurses as really a centerpiece of all safety. And I would add that part of the burnout problem and the workforce problem is actually can be derived from problems with patient safety. In addition to recognizing that it's perhaps adding to it, it's also coming from it, because people who devote their lives to something like nursing, that's a passion. And when you go into a hospital every day and work and you feel like you're harming people in some way, that has to be just a profoundly harmful to you in your heart. I can't imagine that nurses can tolerate that for a very long period of time. So that can cause burnout and turnover. So patient safety it's so important to be focused on it, if only for the workforce, for just keeping your workforce there and happy. But of course, there's other reasons as well. It's for your patients. But it's such an important issue. I'm glad you brought it up.
Yeah, I'm glad we got that question through. I think we probably have time for one last question, which will, I believe, pivot us back to reminding people of how they can stay involved, which is maybe Sue can speak to this, maybe Robert, you can also speak to this, a question around sort of like, wouldn't an executive order to create the board achieve all the same things that legislation to create a board might achieve? Like, why is this action around getting this legislation passed so important?
Yes, and we do think that an executive order could help to establish and stand up a National Patient Safety Board, especially since it would be housed within an existing agency, the HHS. At the same time, we also know that support from Congress is also important. So we have been in partnership with the coalition working on both policy fronts.
Two-sided attack.
Exactly.
Yeah,
And
go ahead,
that's
Sue.
what we saw when we were at PCAST. You know, we were very aware of the efforts of the National Patient Safety Board Act, and we supported that. But when you write an executive order, you can't write an executive order that basically is the same as an act or bill on the floor. So that's
Mhm.
why we called it the team. That we thought it was really complementary. It was, you know, elevating again the need for a federal home for patient safety.
Mhm.
And that PCAST went one step further, and that's to have a office at the White House dedicated to patient safety who would help coordinate all this across the agencies. So it was kind of nice to look at what the PCAST saw as a part of a bigger whole, where the National Patient Safety Board Act is really one very important act, where at PCAST we kind of packaged it with all these other recommendations.
Mhm. Well, that's fantastic. I think we have a last couple minutes, and I'm just scrolling back through some of our questions here. But I want to remind everyone to look into the chat. We've been dropping a lot of resources for people to email their representative, to share their story, to join our coalition, to stay involved with events that are happening, like the march that Sue is running in September and her organization is working on. And we want to make sure that we have everybody joining us in this fight.
Right.
I'm just
Hazel,
looking
can I
at these
make a comment?
ones. Yeah, of course, Sue.
I've been thinking about, you know, all the questions and everything. And, well, first of all, the World Patient Safety Day is it's a global celebration, you know, recognition of the importance of patient safety. It's a WHO global phenomenon, I'm going to call it. So PFPS US is doing kind of a series of events, and you can go onto our website. I know the website's in the chat. And so the march is going to be part of it. We're going to have educational section of that. We're going to be launching Project Pivot, that is looking at patient-reported measures around discrimination, safety, and diagnoses. So it's a really nice package of all these events happening within 2-3 days. The other thing I wanted to say is, you know, I've worn many hats in patient safety. I've been on the outside being a patient, trying to push the system to do more. And then I was inside the system. I worked at PCORI. I worked at CMS. And I think I realized that there is nothing stronger than patients calling for change. The agencies listened. I mean, it was, you know, being in the system, it was hard to really make the change. Being outside of the system, pushing back in. I mean, I have never seen anything more powerful than the patient voice. You know, in looking at the questions, regardless if we all agree with the nuts and bolts of the National Patient Safety Board, I mean, it isn't everything that I think that all patients want. I understand that, but we're going to be safer with it than without it. And, you know, I'm really hopeful that when patients get engaged as the board is set up, that patients can help drive this in a really patient-centered kind of way.
Thank you, Sue. And I want to thank, you again, Robert, for coming on and talking about the board and laying it out so clearly. Leah, for coming and talking about the issue and the work that Leapfrog is doing. I want to be respectful of everyone's time, both people who joined us to speak and also people who came to watch. So I think we will close out the webinar. We want to encourage people to reach out to anyone who's on the webinar today, reach out to Families USA or the coalition, watch your email for all of these resources that we've been putting in the chat so that you can stay involved. And there will be a recording of the webinar so you can come back and hear Sue's incredible story, hear about the work that Leah is doing. And we hope to have you all join us in moving towards having a safer healthcare system that is delivering high quality care for everybody. So with that, we will close it out. And I thank you for joining us today.
Thank you.
Thank you.
Thank you.